It's a real honour to have him here. He's the founding chair and executive director of the Global Centre for Nutrition and Health, based in Cambridge, as well as the co-founder and chair of the BMJ Nutrition Journal. It's Professor Sumantra Ray.
So, good evening, almost, everyone. I'm very pleased to be here, and thanks to David Unwin for inviting me. I'm also very pleased to still have all my own teeth. I'm sort of the interlude between you and the finishing act, because I gather from colleagues that everyone's been very busy talking about different types of nutrients, particularly macronutrients, and of course carbohydrate and sugar within that. But I'm not going to be talking so much about the message, but rather about the methods that we currently use to actually convey messages, to sustain those messages, and then to spread them. So really I'm going to bring us up one level to a wider arena around the knowledge to action cycle, which is a conceptual means of bringing new and emerging knowledge into practice. And we're going to talk, we being on behalf of the Global Centre that I represent, I will be talking a little bit about our journey around bringing nutrition into healthcare practice. These are just some of my declarations of interest. We all try to be unbiased in science, but we're all shaped by the different hats we wear. As you can see, I have a number of them, and so the views that I represent may not necessarily reflect the views of the organisations I'm connected with, but I'm very interested in new and emerging scientific dialogue. So, this is really probably how you feel at this moment. This is a bust from the Fitzwilliam Museum, so if all of this is really a little bit of an interlude, feel free to lie back and enjoy this segment of the flight. I will say that there are a few slides that I have that are excerpts from hitherto unpublished papers, particularly 4 or 5 slides, and I'd be happy to provide a redacted copy of my slides to the conference organisers afterwards. But really, we have a light menu, and the first bit of the menu isn't really about nutrition, but rather about implementation science being a bridge between research, education, and practice. And then I'll go on to tell you a little bit about our 10-year journey, and really how we've begun to beat a bit of a path for nutrition education in healthcare practice. So, common knowledge or common sense, not always commonplace, but really a simple way of looking at implementation science would really be to talk about the right research done in the right way. So research done specifically to inform how we can make the right thing to do also the easy thing to do. So this is really something that helps us to move evidence from what we used to think of as evidence-based, that takes evidence through a long policy cycle before it goes into practice, but rather move to more evidence-informed approaches that are sensitive to critical masses of evidence as they are emerging. Why bother to think about all of this? So these are some general numbers. So about 1/3 of the patients under our care don't receive treatments of proven effectiveness. About 1/4 of patients receive care that's not actually needed or could be potentially harmful. And 3/4 of patients may be provided information, or rather are not provided information that they actually need to make informed choices. And possibly over half of the physicians or other types of doctors who need evidence as tools don't have that to hand at the moments that they need it. So all of this comes from the Canadian Institutes of Health Research, from a very generic clinical practice perspective. And the knowledge to action cycle is really something that's promulgated as a means of taking evidence and putting it through a continuing cycle that tries to mitigate some of these knowledge gaps. But this is to do with general healthcare evidence. So thinking about nutrition, the situation is possibly far worse because for mainstream, if you call it that, medical specialties, this is the challenge we're faced with, so one can only imagine what the situation might be for nutrition. But implementation, at the end of the day, is all about improving healthcare. It's not about writing fancy papers. So we need to think about what quality gaps we do have to address. What are the interventions that we have to hand that are ripe and ready to go? And then think about the how, the where, and the partnerships that we need. And these partnerships are often underemphasized. And of course, the doctor-patient or the health professional-public partnership of all partnerships is often the one that is overlooked when we focus particularly on organizational partnerships. So the services that we're delivering, we need to think about what they could be rather than what they are and simply superimpose new things on existing services. And there are ways of looking at this systematically, particularly in terms of quantifying quality gaps and within that looking at the quality of specialist services. So you can see a couple of suggested ways of doing that. For instance, the number receiving care by the total number of service recipients, quite easy for someone to compute in or estimate in primary care. But when you do this for specialist services, and when you do this particularly thinking about a gap in a specialist service, the numbers come out as slightly surprising. So really, we do have a number of effective interventions in nutrition, and it's time to start delivering them. And really, going back to the how to do that, and the strategies that we have. So passive dissemination is what we tend to spend a lot of our resources on, particularly in primary prevention. But there's a good body of evidence now to say that passive dissemination is not very effective. And training is a frequently used strategy which is beginning to actually emerge as something that has longitudinal impact and something that can change knowledge, attitudes, and practices if we deliver training in the right way to the right people. And that means actually delivering training at different levels and different components of training depending on the sector that we're looking at. And perhaps we'll come back to that later. So some of the implementation outcomes often get conflated with clinical outcomes, but just want to make the point that the two things are distinct. So you could have an effective intervention, beautifully framed, poorly implemented, or you could have a fairly ineffective intervention, which is actually positioned in a way that people want to implement, so they have the will to do it, and it's successfully implemented without that much attention to the actual quality of what underpins that intervention. And I'm purposefully being quite generic in the way that I'm positioning this, but I suppose that you can all apply this to some of the topics of interest within nutrition that you care about and perhaps that you have been discussing so far. So there's a nice body of evidence from Price and colleagues to say that implementation through education, which is slightly different to training that focuses on skills. So education and training together could sound like semantics, but really what Price and colleagues mean is that using education with training means that you're telling people why they should be doing what they're doing rather than simply giving them the knowledge and teaching them technical skills. And that seems to be one of the most readily available, cheap to implement things that we can do. But why is it not done? And that's a very good question. Because it actually requires more thinking than you might imagine. Developing materials which tell a story, that are harmonized across different geographical sites, across different professions, to actually train the trainers so that we can have a critical mass of individuals delivering a message consistently and actually sustain and spread, but also informing and getting stakeholders on board. And without that, a lot of efforts are either lost or there are competing efforts, and that really confuses people. Licensure, accreditation, certification. So these are all ways of quality assuring training, but also quality assuring the competencies that training provides. And these things cannot be pulled out of a hat. So there's a difference between just spreading awareness and embedding training and putting depth into that by giving people the educational basis for that. So what we've been doing really is to take the implementation science paradigm, the knowledge to action cycle, and try to build some of the basic blocks of what can be a program of intervention across different areas of nutrition. But I'm going to take a step back to actually talk about a concept. So this is a rather busy slide constructed by a very clever colleague at the University of North Carolina called Barry Popkin. And if you look at this from left to right, you'll see that there are different patterns of evolution that it refers to. So Paleolithic man going through settlements, industrialization, a pattern of non-communicable diseases, and of course this utopian pattern of desired societal change that we're all working towards. But in fact, one of the problems in looking at this sort of paradigm is that we don't live in these tight compartments. And the flashing circles represent the fact that there is actually a complete overlap now of two different patterns that we're seeing. So pattern 2, which is when settlements first began, cereals began to dominate. It was still labor intensive. There are still lots of people in the world who have labor intensive lifestyles. They have different sorts of nutritional problems. They have specific nutrient deficiencies. But again, we see the pattern of non-communicable disease associated with oversupply. And then we see the two things overlapping. And this is what leads to the challenge, or conundrum, I might say, of an under and overnutrition double burden. And this is associated with a number of different chronic diseases. So I imagine you will have talked about type 2 diabetes as one of them, but it's not the only one. And of course, it's also associated with micronutrient deficiencies. But not only does this happen in the same populations, but also the same individual can be exposed to both under and overnutrition and micronutrient deficiencies through the life course at different moments, and that actually gives each individual quite a unique metabolic and nutritional risk profile, which cannot necessarily be treated with a blanket approach. And that's perhaps where a lot of population science guided approaches, which have excuse the pun, the one size trying to fit all, is often missing some of these inter-individual trajectories that are unique to each person. But this is a challenge. It's not just a challenge to us treating or preventing in individuals. It's also a challenge to how we position the message, how we allocate resources, and how we formulate national policy. But thinking of a triple burden that involves under and overnutrition and micronutrient deficiencies together, and thinking of agile strategies to implement evidence to deal with individuals or populations is really the best that we can do under the circumstances, because we have quite a big problem globally. And let's not forget that we're a very tiny collection of individuals sitting in rather privileged circumstances, but most of the world's population lives elsewhere and under different circumstances. But no matter which way we look, you can see the Global Nutrition Report tells us that there are actually a couple of billion people who lack key micronutrients. There are alarming numbers, particularly children, who are both over and undernourished, often in the same countries. So one of the ways in which the world has tried to tackle this is through the creation of Sustainable Development Goals, and that's become a little bit of a catchphrase in recent times. But what it really means is looking at the different root causes, and you can see here the sustainable food production, infrastructure, health systems, which we're talking about a bit, equity and inclusion, and also things like peace and stability. So all of these root causes need to be looked at in relation to how they contribute to dietary choices, which actually leads to dietary patterns, and those patterns then lead to a particular nutritional status that then impacts health outcomes. So without going into the root causes and the wider determinants, it's actually very difficult to tackle the tide of nutritional burden that we're facing. So the way we try to make a tiny contribution to this ourselves is to apply the knowledge to action cycle in a particular way. So we start by assessing and identifying knowledge gaps on the ground. So we look at different clinical scenarios or different public health scenarios, and we ask why those gaps exist. Is it because the evidence isn't there? Is it because the quality of the evidence is variable? Or is it simply because the evidence is there, but it's not collated and synthesized in a way that can be conveyed to people? And by people, we tend to mean practitioners, and I'll explain in a moment why we focus on that segment of society. What we then do is really develop and deliver education and training interventions. So whilst we also do quite a lot of primary research, as a number of academics do, we do population studies, we do randomized controlled trials, we do pieces of evidence synthesis, and we publish those as other academics do. But the fun for us really begins when we begin to collate all of that, not by doing yet another systematic review, but by doing an umbrella synthesis that can inform a practice-based educational intervention. And I say educational because we want people to know why they're doing something, and to actually impact not just their knowledge, but their attitude, so that that can sustain some changes to practice. And then we tend to evaluate those as we go forward. So we look at what happens down the line. Do practitioners internalize that knowledge? Do they change their practices? If not, what are the barriers that come up and how do they navigate them? And does this actually reach patients and the public? And if so, what does that look like and can it be quantified? So ultimately, the goal of all of this is to get into the top right-hand corner of this box. So we want the public and patients to have confidence in both the competence and the level of care that practitioners, health practitioners in particular, are able to provide. And we still have a little way to go, not just in nutrition, but I'm going to focus my comments on nutrition for now. So our approach to this is to try and harness, using the knowledge to action cycle, this entire step ladder of research that's happening all the time. And some of us were at a very interesting meeting just under a year ago, where we had a lot of research presented from certain segments of this ladder. So very often that's the research that is making headlines, research that actually looks at sciences around associations, but also there's research beneath that. There are mechanistic studies, there are underpinning mechanisms to think about as we are challenged by changes to some of the mechanisms and our assumptions around physiology. So what we really ought to be doing is looking across, or rather up, this entire ladder, and what we ought to be doing is putting together an umbrella synthesis of the sum total of evidence from different types of studies, and really that's where our job begins to try and translate some of that to healthcare practitioners. So if you look at the amount of research that is funded all the way up that ladder, it's astounding how much investment there is in all of those different types of scientific research, but very little research actually makes its way into the healthcare practitioner's kitty. And the reason for that is because there isn't research or a systematic program of research into how healthcare practitioners might actually change their behaviors in terms of how they advise patients and the public, and in turn associated research that looks at whether members of the public or patients who can make choices actually internalize that. So there are probably just over a couple of hundred peer-reviewed papers in the field of healthcare education research pertaining to nutrition, and about half of those are ours, which is not a good thing. It means that they are filtered through all the biases that I showed you at the very outset that are associated with who we are and what we do. And really, what we would like to see is a community of researchers all adding that piece to this more traditional stepladder. So how this all started 10 years ago was really when we were born out of the University of Cambridge as a strategic partnership, now close to 200 doctors, dietitians, nutritionists, and other types of professionals. And we're anchored in Cambridge, but we work without borders. And for the first 5 years, we were really thought to be very odd. Which academics start with the problem on the ground and work their way backwards to think about what trials they might do, because most academics write a paragraph at the end of their grant applications on pathway to impact, and we'll disseminate all of this when we've published our Lancet paper, so on and so forth. But actually, this upside-down model was initially thought to be odd, and then from 2015, it started becoming recognized as something that was implementation science. We thought, that's really interesting. Oh, gosh, we've been doing that for a while now, but just didn't know it. And really from that, what we have got is now a network of individuals who are bound by a common philosophy, and that is not just to get research out there, it's to do research in a way that can be put out there, and you need to think about that design up front. So I must say that we've had a lot of help from a number of strategic partners who have powered us over the years, and you can see that this is a diverse group of university institutions and specialist organizations, and of course many, many others who've been part of collaborations. So this has allowed us to think of creating a community that's agile in the sense that everywhere we work, what we try to do is create a global knowledge exchange faculty by bringing in local partners, local nutritionists, practitioners, and really embedding knowledge locally so that within 5 years of starting any initiative, we make ourselves redundant such that the people who we're working with are running at full capacity themselves. And really our aim is to try and do that not just globally, but also more locally. And in doing so, what we try to do is bring everyone together once a year to a summit where we actually discuss consensus on the way forward. So these are successive themes of summits that have happened, and the 5th one is about to happen this July in Cambridge. And this is not a conference, it's actually a consensus piece that in fact challenges some of the assumptions around what we should be doing, gives us a target for the next year, and then we all go away and try to meet that target or those targets and come back. But what we also do in the process is try to create a critical mass of change drivers, and we train people from different professions through Cambridge University Institute of Continuing Education, and we give them foundation certificate training in applied human nutrition so that people who are interested in the topic of nutrition but haven't had the chance to think about some of the underpinning physiology, biochemistry, and some of the other nuts and bolts actually are empowered so that they can take that knowledge away and begin to apply it in their own contexts. And we have an academy that then tracks these individuals as they go back to different parts of the world and different organizations. And really, we're always surprised by how innovative people are. And we're always amazed at the fact that the people who we train come up with much better and much more innovative ideas than those of us who are sitting in academia and providing the training. So it's really quite an illuminating and humbling process. So I was talking about the wider determinants, and this is what we've learned, that actually for many years, the nutrition and health community has been focused very much here on trying to control dietary choices by doing RCTs and epidemiological studies and trying to take those and impact nutritional status and health outcomes. But really, what we have learned through a series of, I suppose, trials and errors is that we need to, even if we're focusing here, think much further upstream about food production, nutrient quality in the food environment, particularly if we are thinking of education and training as a key implementation strategy. And that, on one hand, is challenging because the forces that govern food production, the way in which nutrient quality is measured and communicated, and the manner in which the food environment is constructed is dictated very often by political and economic forces. And no amount of advice given by the health practitioner here can counteract the sheer push of all of those forces unless health practitioners and other practitioners together begin to actually use the same knowledge base to educate and train individuals in all of these segments. And by doing so, what we've found in the last 5 years is actually you don't need additional knowledge, you simply need to position your message differently. And that is beginning to create hope that we can have a whole systems approach that will actually show up further down the line when it comes to dietary choices. Why have we chosen practitioners as the focal point for the knowledge to action cycle? By the way, these ellipses are not proportionate, but really patients and the public are at the heart of everything. But the only problem is that public memory is short, and public memory is often swayed by the force of whatever it is that is coming at people through advertisement and all sorts of other means. But also, it's not very responsible for those in the scientific and healthcare community to simply hand a load of complex facts, which may often be changing, to the public and expect them to keep up with it. Of course, we need to influence researchers and innovators and encourage them to do more practice-relevant research. We do need to talk to policymakers and other public influencers, but above everything, what we have thought of as an achievable strategy is really to embed knowledge within practitioners for two reasons. One is because all statutorily regulated healthcare practitioners have a legal responsibility to tailor treatments appropriately to patients in front of them or give appropriate advice to the public. And they also have a responsibility to keep up with the evidence base. So as a colleague of ours rightly says, in nutrition exams, the questions are the same every year, but the answers could often be different. And we need to not be disconcerted by that, but rather embrace that and internalize the skills within the health practice community so that doctors, nurses, dietitians, and other practitioners are all comfortable about keeping up with the evidence base in a way that can actually impact healthcare practice. So in order to aid that process, last year we launched the BMJ Journal of Nutrition, Prevention and Health, and some of you will know the editor of the main BMJ, Fiona Godley, who is really putting out a call to action to say that the doctors of tomorrow must internalise nutrition as part of their knowledge. But really it goes far beyond doctors, because all types of healthcare professionals need to have a common denominator of knowledge in nutrition, but also know where the boundaries lie and where their expertise ends and where they might need to refer to more specialised individuals. So the 4 pillars that we are basing our forward look on are really education and training as one of them, implementation research as another, classical research and innovation sensitive to practice, but also looking at nutritional equity and population health. And inequities are a key driver which are often internal to families, communities, and individuals. So this is the sort of nice wallpaper that I look at on a rainy day, thinking about what we've done over 10 years. But the reality is, actually, we're still standing at the bottom of a bit of a mountain. And that mountain has a lot of learnings in it. So the first bit of learning was really that in order to in fact, create some sort of policy framework, you need quite a lot of partnership working and tightrope walking. And a number of years ago, the Council of Europe came up with various recommendations. Those recommendations still hold good on how we can improve nutrition and health systems. And then we worked together with a number of different professional organisations. And just as we were sort of beginning to think, gosh, this is going to be a horse made by committee, suddenly the BBC came along and did something useful, and they actually made a documentary on nutrition risk in the NHS. And then that led to a Department of Health mandate, which was only a paragraph to say that there ought to be a nutrition education project focusing on building the architecture. And that sort of mandate is immensely useful, and that is the mandate on which a lot of our efforts have been based. So we started really at the root. So we started about 10 years ago with an intervention across 15 medical schools. We trained a couple of hundred medical students in different aspects of nutrition, and we then even surveyed their knowledge, attitudes and practices longitudinally, and we felt really happy. And then people said, so what? They're going to join the National Health Service or some other health service, and all that knowledge is going to be lost because they're not going to be able to tackle the barriers in the system. So at that point, really, we did another study which teamed up with management and leadership colleagues, because we realised that simply giving nutrition knowledge or technical knowledge to practitioners without also giving them some change management and leadership toolkit means that they can't internalise or navigate the barriers or harness the opportunities. Based on that, we were then able to create the blueprint of a curriculum. We started that in Cambridge and ran that curriculum for a number of years, which eventually became subsumed in lifestyle medicine, which we see as a good thing because that's no longer nutrition in isolation. And then we began to think, so what about other people, pharmacists, for instance? So the second largest health profession in this country, and we began to actually look at the potential for the high street pharmacist to provide evidence-based or evidence-informed nutrition advice, and we very recently published a synthesis on this. And then we began to look at things in primary care. And very interestingly, we were given the topic of hydration, and we were asked to look at whether or not we could put together a model to talk to GPs about hydration education. And we were told, oh, it's going to be impossible to change anything in primary care, it's not going to work, GPs don't have the time. And we were astounded by the openness and open-mindedness, and it simply is the way in which messages are positioned in terms of relevance to clinical practice. And no matter what the topic, I believe the same does hold good if you've got the right method of messaging. And then, of course, nutrition education for researchers. So there are researchers who've done research on one molecule for 20 years and have become world experts on absolutely everything to do with nutrition. And sometimes it's good for those researchers to take a step back and look at the common denominator of what's actually facing patients and the public and the challenges in the healthcare system. So we then found, working across 12 countries, that actually we have way, way more in common than we have apart. And there's a series of papers that demonstrate this time and time again. And even a nutrition care pathway that looks at both under and over nutrition and micronutrient deficiencies that we've developed with Canadian government funding across 4 provinces of Canada that's now internalised into secondary care policy. But very interestingly, many of the recommendations that now come from that need work in primary care. So based on all of that, there's a cross-border picture that tells us that, in fact, educational interventions need to improve in their quality and sensitivity. And this is a nice synthesis that tells us how some of those education interventions can be much more sensitive to the healthcare environment rather than create theoretical interventions that can never really be implemented. And of course, again, the BBC comes into the picture a number of years later, and many of you will have heard a series of different radio and also some associated TV episodes that all bring nutrition further up on the agenda. So these moments tend to come every 10 to 15 years, and we seem to be in one of those moments now, and there is a little bit of a wave of opportunity to ride, particularly thinking about the way we're repurposing medical education in the UK. So this is the General Medical Council's Professional Values and Behaviours Framework. And in fact, there's now a framework around nutrition competencies that mirrors the General Medical Council's principles. And these are thought to be generic professional capabilities. So if something is internalised as generic and as part of professionalism, we're on a winning streak and we can begin to embed new knowledge. And this is a study, that's what we do, an educational action research piece that we're doing to determine what nutrition education policy might look like for UK healthcare. And some of the insights into express nutrition training needs are that most doctors recognise the need for a multidisciplinary approach, but more so in hospital than in primary care. And that tells us there's still more work to be done in primary care. But in fact, we still need studies to identify the ideal method. But my take on this is that there isn't one, and so we need to have as many methods as possible which work for different types of doctors and healthcare professionals. So there are a number of opportunities in front of us in the UK. I'm not going to read all of these, but one big opportunity is also the fact that over the last 10 years, our government here has invested about £17 million in doing the National Diet and Nutrition Survey, which provides a very detailed population risk assessment in terms of diet and nutrition. And those data are publicly available. So one could imagine doing a very population-sensitive risk management, particularly through education and training and clinical interventions in primary care. And one that would be sensitive to all elements of diet and nutrition and not just one or two. But there are some challenges, and there's a whole traditional lack of nutrition in curricula, and we don't necessarily have very good role modelling in terms of clinical champions who medical students and tomorrow's doctors and other types of healthcare professionals might aspire to be like. But really, one of the ways in which we're trying to work with other organisations in this space is to build a coalition, and we're currently working with a medical student body known as NutriTank, and also a dietitian-nurse partnership known as ERIN. And this is really so that we can begin to showcase those examples begin to actually model what champions look like in a healthcare setting, but also do that with some sort of unified voice and connect that to what's going on in the wider world. So about what's going on in the wider world, really our 2025 vision is to create an international knowledge application network in nutrition in line with the 2025 goals of the UN decade. And that knowledge network will have a number of different components that really ought to bring to life the machinery that I've been talking about so far, and to actually hand that to different parts of the world, including this one, but a piece of machinery that allows us to look at open data, information, and have interpretation done by people who know what they're talking about, and also create local examples of what good practice looks like. So there's this interesting word, glocal, that wasn't coined by me, and that is to think globally but act locally. So in different countries, that looks different. So for instance, in India, where we do a lot of work, the way in which we have begun to create a model and collect data around that model to see how it works is to use something known as a mobile teaching kitchen. Those are two of my medical students actually out there collecting data, and to actually create a community of culinary health educators from some of the most marginalized members of society. And what we've learned from this is that, in fact, some of those societies, so they spend about the equivalent of 25p a day on food, and they will generally choose foods that they see the rich folks having. And what do you think is in those foods? I'm not going to say, but I think you know the answer. And it has been an astounding journey to actually educate these people on why they should be changing those choices and how they can do it still within their 25 pence or 20 rupee budget and still have actually low GI, high nutrient value and higher protein foods, which in fact have now led to 3 template menus that 12 trained culinary educators use to not only educate their own community, but run a micro-enterprise that serves white-collar society in that particular part of the world. And the data around this tells us that we can actually bring this model back to the UK and to a number of other countries, and we have a plan to do this over the next few years to look at how this mobile teaching kitchen concept, which is simply a vehicle and a Trojan way of operationalizing learning, can bring doctors, other nutritional health professionals, volunteers, lay members of the community, particularly those from marginalized sections of the community, together to have an upwardly mobile impact. And of course, doing some systems work, I'm currently privileged to have the opportunity to work with the World Health Organization as a consultant to actually put together the architecture map for medical nutrition education at a very exciting moment when the World Health Organization is moving towards more implementation from having simply done a lot of normative work in the past and actually thinking about universal health coverage. There are lots of content discussions to be had, which we're not involved in, but the systems architecture is something that we are thinking about. And some of the learnings really are that literacy and nutrition literacy don't necessarily move together. Using cooking skills as a medium is often very useful to circumvent a lot of barriers. And from the data that we are collecting, which are still unpublished, though they have been presented at conferences, we've collected data on cognitive flexibility and mentalizing skills, which are actually improved by using culinary methods of education. And we've talked about the upwardly mobile impact, but really using these out-of-box methods could be a way for any healthcare professional to serve communities in lesser resource settings. So the big challenge on our table is the global one, but this is about ending malnutrition in all of its forms, under, over, and micronutrient deficiencies, and medical education is still a missing key. So this is a little bit of forward look that I won't bore you with, but what I will say is that this is what the Cambridge Biomedical Campus looks like, because now the AstraZeneca headquarters are located there, and you can see it's very structured and it looks very nifty. And just the back of the biomedical campus is open fields and blue skies, and that's still where we are in terms of a lot of our different pieces of understanding, and that is why it's so important to have an open mind for an open future. Thank you very much.